This is the confession of Nora Whitfield, a cardiac intensive care nurse who worked at Providence Regional Medical Center in Everett, Washington for 11 years. She reached out to me after seeing some of my work documenting unexplained medical phenomena, and what she told me over the course of 3 conversations fundamentally changed how I think about the relationship between consciousness and the human heart. Nora asked that I share her story exactly as she told it, in her own words, because she believes other healthcare professionals may have encountered similar cases without recognizing them for what they were. What follows is her account, reconstructed from our recorded interviews. My name is Nora Whitfield, and until 6 months ago, I was one of the senior nurses in the cardiac intensive care unit at Providence Regional Medical Center. I had my bachelor's degree in nursing from Seattle University, my CCRN certification, and additional specialization in advanced cardiac life support and hemodynamic monitoring. I'd spent 11 years learning to read the subtle language of failing hearts, the way a pulmonary artery catheter's waveform changes when cardiac output drops, the specific sound of pericardial friction rub, the precise titration of vasopressors needed to maintain perfusion pressure in cardiogenic shock. In those 11 years, I saw hundreds of patients in various stages of heart failure. I'd watched people code and come back. I'd held hands during last breaths. I'd seen hearts stop and restart with enough defibrillation. I thought I understood the mechanics of cardiac death as well as anyone could without being a cardiologist myself. The heart was a pump, an extraordinarily sophisticated pump, yes, but ultimately a mechanical system governed by electrical impulses and pressure gradients. When it failed, we knew why. When patients deteriorated, the monitors told us the story in real time through telemetry readings, lab values, and hemodynamic parameters. I believed in the science completely. I trusted the equipment. I knew that the heart had no consciousness, no awareness, no ability to do anything except respond to the electrochemical signals that controlled its contractions. It was beautiful in its complexity, but it was fundamentally predictable. Then I met patient 2847, and everything I knew became a lie. The CICU at Providence Regional is a 24-bed unit on the 6th floor of the main hospital tower. We handled everything from post-surgical cardiac patients to acute myocardial infarctions to end-stage heart failure waiting for transplant. The unit was divided into pods of 6 beds each, with central nursing stations equipped with banks of monitors displaying continuous telemetry for every patient. The beds themselves were arranged to allow constant visual observation. No patient was ever out of sight of the nurse's station. We had the latest hemodynamic monitoring equipment, including Swan-Ganz catheters for measuring pulmonary artery pressures, continuous cardiac output monitors, and arterial lines that gave us beat-by-beat blood pressure readings. I typically worked the night shift, 11 p.m. to 7 a.m., which meant I was there for the quietest hours when most patients slept, and the unit settled into a rhythm of hourly vital signs checks and medication passes. I preferred nights. The pace allowed for more focused patient care, and I developed a reputation for catching subtle changes before they became emergencies. It was April 14th, 2024, just after midnight, when they brought in the patient who would end my career. The admission came through the emergency department as a STEMI, ST elevation myocardial infarction, meaning a major heart attack in progress. The patient was a 63-year-old man named Dennis Callahan. According to the paramedics' report, he'd collapsed at home with crushing chest pain. His wife had called 911 immediately. They'd gotten him to the hospital within 30 minutes of symptom onset, which meant he was a good candidate for emergency cardiac catheterization to open the blocked artery. Dr. Lansing, our interventional cardiologist on call, took him straight to the cath lab. They found a complete occlusion of his left anterior descending artery, the widowmaker blockage. They placed a stent successfully, restoring blood flow to the damaged heart muscle. The procedure went smoothly, all standard protocol. When they wheeled him into the CICU at 12:47 a.m., he looked like any other post-cath patient. He was sedated but responsive, with the femoral artery access site from the catheterization still requiring close monitoring. We got him transferred to the bed in pod 3/18. I introduced myself while connecting him to our monitoring system. His telemetry came up on the screen showing normal sinus rhythm at 78 beats per minute. Blood pressure was 118/72. Oxygen saturation was 96% on 2 liters of nasal cannula. All the numbers looked good. The cardiac enzymes that measured heart damage, troponin and CKMB, were elevated as expected from the infarction, but not catastrophically high. He'd gotten to us in time. I completed his initial assessment, checking the catheterization site for bleeding, listening to his heart and lungs, verifying that all the monitor leads were properly attached. Everything was exactly as it should be. His wife, Joyce, stood anxiously at the bedside, her face exhausted from fear. "He's going to be okay," I told her, because that's what the data said. "The stent is in place. The artery is open. We'll monitor him closely, but he got here fast enough to prevent serious damage." She nodded, crying with relief. "Can I stay?" "Of course. There's a chair right here." I showed her the recliner we kept in each patient space. "I'll be just outside at the nurse's station. You can see me through the glass. If you need anything, press this call button." She thanked me repeatedly. I gave her the standard post-MI education, what to expect over the next few hours, the medications he'd be on, the recovery timeline. Then I left them to rest and returned to the central station where I could watch his monitors along with my 5 other patients. For the first hour, everything remained stable. I charted his admission data in the electronic medical record, verified his medication orders with pharmacy, and made my rounds to check on the other patients in my assignment. At 2:15 a.m., I did his first post-admission vital signs check. All parameters were unchanged. Heart rate steady, blood pressure stable. The continuous ST segment monitoring showed no signs of reocclusion. I was back at the nurse's station, reviewing labs for another patient, when I noticed something odd on Callahan's telemetry display. It was 2:43 a.m. His heart rate had suddenly jumped to 98 beats per minute. Not dangerous. Many things could cause a slight tachycardia, but it had been rock steady at 78 for 2 hours. I watched for a moment. 98, 99, 100. Climbing slowly but steadily. I stood up to get a better look at his bed space through the glass partition. The lights were dim for night, but I could see both him and his wife clearly. She was asleep in the recliner. He appeared to be resting quietly, eyes closed, breathing normally. 102 beats per minute, 104. I walked into the room to assess him directly. "Mr. Callahan?" "Dennis." His eyes opened. He looked at me without apparent distress. "How are you feeling?" I asked, already reaching for his wrist to feel his pulse while watching the monitor. "Any chest pain? Shortness of breath?" "No," he said. His voice was calm. "I feel fine." I felt his radial pulse. It was rapid but regular and strong. His skin was warm and dry, not diaphoretic. His color was good. Respiratory rate was normal. The pulse oximeter showed 97% oxygenation, 108 beats per minute. "Your heart rate is going up a little," I said, keeping my voice reassuring. "Do you feel anxious? Does anything hurt?" "No," he repeated. "Nothing hurts. I'm not worried." I looked at his wife. She was stirring awake, sensing the activity in the room. "Is everything okay?" "His heart rate is elevated," I explained. "It's not dangerous, but I want to figure out why. Sometimes pain or anxiety can cause it. 112 beats per minute. This wasn't normal. Post-MI patients could certainly develop tachycardia from pain, from anxiety, from early heart failure, from atrial fibrillation. But he denied all symptoms, and his rhythm was regular sinus. I checked his arterial line blood pressure, 124/76, actually slightly better than before. I stepped out to grab Dr. Lansing's number. She answered on the second ring, used to night calls. I explained the situation. "Any chest pain?" she asked. "None." He denies any discomfort. "Pressure's good. No arrhythmias, just sinus tach climbing for the last 10 minutes. Could be early compensatory response to reduced cardiac output. Watch the blood pressure closely. Get a stat 12 lead EKG. If the rate hits 120 or the pressure drops, give him 25 of metoprolol IV. Call me back if things change." Standard orders, exactly what I would have expected. I hung up and returned to the bedside. 118 beats per minute. I'm going to do another EKG, I told them. I rolled the machine over, placed the electrodes on his chest, and ran the test. The machine printed out the tracing. I studied it carefully. Normal sinus rhythm. No ST changes to suggest reocclusion. No peak T waves to suggest hyperkalemia. No signs of pericardial effusion or tamponade. Just a fast but otherwise normal heartbeat. 122 beats per minute. Mr. Callahan, I said, my voice more serious now, I need you to be completely honest with me. You're not having any pain at all? No pressure in your chest? No nausea? No feeling like something's wrong? He looked directly at me. His eyes were clear and cognizant. I promise you, I feel completely fine. Better than fine, actually. I feel good. That was not a normal thing to say. Post-MI patients don't feel better than fine. They feel exhausted, sore, worried, but his facial expression matched his words. He looked calm, almost serene. 128 beats per minute. I'm going to give you some medication to slow your heart down, I said. I drew up the metoprolol, checked it twice as protocol required, and administered it through his IV. We waited. Beta blockers like metoprolol typically work within minutes to decrease heart rate by blocking the effects of adrenaline on the heart. 130 beats per minute. I felt the first whisper of unease. Metoprolol should be working by now. I checked my watch, timing the dose. 5 minutes, 6 minutes, 132 beats per minute. Not only was it not decreasing, it was still climbing. Nora? It was Kelsey Baxter, another nurse on the shift, calling from the station. His pressure okay? I glanced at the arterial line monitor. Yeah, 128/80. Pressure's actually going up too. That made no sense. With a heart rate climbing into the 130s, especially in a heart that had just suffered an infarction, blood pressure should be dropping as the weakened muscles struggled to keep up with the increased demand. Instead, his cardiac output appeared to be improving. 136 beats per minute. I'm calling Lansing back, I said. The cardiologist sounded more concerned this time. The metoprolol did nothing? Nothing. Rates still climbing. But here's the thing. His pressure's going up too. He's at 130/82 now, and he has no symptoms. Says he feels great. A pause. That's not right. His post-infarct heart shouldn't be able to sustain that output. You're sure the pressure reading is accurate? Arterial line. Direct measurement. Another pause, longer this time. I'm coming in. Don't give any more rate control until I see him. Get a stat echo to check his cardiac function. And Nora, watch him closely. I hung up feeling truly unsettled now. In 11 years, I'd never had a cardiologist sound uncertain like that. 142 beats per minute. I ordered the emergency echocardiogram and called for the night tech. While waiting, I did another full assessment. Heart sounds were normal, regular rhythm, no murmurs, no extra sounds. Lungs were clear. Peripheral pulses were all strong and equal. His skin remained warm and well perfused. The Swan-Ganz catheter we'd placed during admission showed his cardiac output was 6.2 liters per minute, well above the normal range of 4 to 8, and remarkably high for someone who'd just had a major MI. Nothing about this made physiological sense. Nurse? Joyce was standing now, frightened by all the activity. What's happening to him? His heart rate is higher than we'd like, I said, trying to sound calm. The doctor is coming to evaluate him, but his blood pressure is good, and he's not in any distress. I don't understand. Is this bad? I didn't know how to answer that. By every objective measure, he should be in trouble. But by every objective measure, he appeared to be thriving. 148 beats per minute, the echocardiogram tech arrived and began the ultrasound examination of his heart. I watched the screen as she scanned through different views. The heart chambers appeared normal in size. The valves opened and closed properly. But then she got to the left ventricle, the main pumping chamber that had been damaged by the blocked artery. She scanned it twice, frowning. That can't be right. What? I leaned closer. His ejection fraction, the percentage of blood his left ventricle ejects with each beat, it should be reduced after an LAD infarction. Usually drops to 40 or 45% in the acute phase. His is measuring at 65%. That's above normal. I felt my skin go cold. Check it again. She did. Same result. The portion of his heart that should have been weakened by oxygen deprivation was contracting more forcefully than it should have been capable of. The area that was blocked, I said. The anterior wall. What does that look like? She focused the probe on that region. We both stared at the screen. The anterior wall of the left ventricle showed normal wall motion. No hypokinesis, no akinesis. No sign whatsoever that it had been deprived of blood flow for over 30 minutes just a few hours earlier. I don't understand, the tech whispered. It should be damaged. We should see areas that aren't contracting well. 154 beats per minute. Dr. Lansing arrived while we were still staring at the echo screen. She took one look at the monitor displaying his telemetry, and her expression hardened into clinical focus. She reviewed the echo images herself, then examined the patient directly, listening to his heart, checking his pulses, reviewing every finding I documented. Finally, she turned to me. Show me the cath lab images from tonight. I pulled them up on the computer. The initial angiogram showed the complete occlusion clearly. The left anterior descending artery was totally blocked. The subsequent images after stent placement showed the artery open, with good flow restored. How long was he occluded? Dr. Lansing asked quietly. I checked the timeline in his chart. From symptom onset to reperfusion, 43 minutes. She shook her head slowly. That territory should be infarcted. We should see damage on the echo. And his cardiac output. She trailed off, looking at the hemodynamic display. This doesn't make sense. Post-MI hearts don't do this. 160 beats per minute. Should I try another beta blocker? I asked. Esmolol drip. No. Her voice was sharp. I don't want to suppress whatever's happening until I understand it. His heart is compensating somehow. Maybe hibernating myocardium that's recovering faster than expected. Maybe the occlusion wasn't as complete as it appeared, but something. She paused, choosing her words carefully. Something unusual is happening here. Over the next 2 hours, we ran every test we could think of. We repeated cardiac enzymes. Troponin levels were actually decreasing when they should have been peaking. We checked electrolytes, thyroid function, arterial blood gases. Everything came back normal. His heart rate stabilized at 162 beats per minute and stayed there. Not climbing anymore, but not responding to medication either. And through it all, he remained completely asymptomatic. No chest pain, no shortness of breath, no fatigue. His blood pressure held steady at 132/84. At 5:30 a.m., with dawn starting to lighten the windows, Dr. Lansing made the decision to move him to our highest level of monitoring. I want continuous echo, she said. Set up the transesophageal probe. I want to watch his cardiac function in real time. The TEE probe, transesophageal echocardiogram, involved passing an ultrasound probe down the patient's esophagus to get detailed images of the heart from inside the chest. It was invasive and uncomfortable, usually reserved for surgical cases or complex diagnostic problems. You think something structural is wrong? I asked. I think something is very wrong, she said quietly. I just don't know what. We prepared him for the procedure, explaining what we were doing. He remained eerily calm, almost placid. Whatever you think is best, he said. I sedated him with midazolam and fentanyl while Dr. Lansing positioned the probe. The detailed images came up on the screen, and that's when we saw it. His left ventricle was contracting with completely synchronized, powerful movements. But more than that, it was contracting at a rate that didn't match his electrical rhythm. Look at the electrical tracing, Dr. Lansing said, pointing. His EKG shows 162 beats per minute. Count the actual mechanical contractions. I watched the ventricle squeeze and relax on the ultrasound image, counting silently. 1, 2, 3, 4, 5 contractions in 3 seconds. That's 100 per minute, I said. His heart is beating mechanically at 100, but the electrical activity shows 162. We looked at each other. This was impossible. The heart's mechanical contractions were caused by the electrical impulses. They couldn't be different rates. It violated every principle of cardiac physiology. The monitor must be picking up artifact, I said, desperate for a rational explanation. Muscle tremor or something, creating extra electrical signals. But when I looked at the EKG tracing, it was clean. Clear P waves, clear QRS complexes, no artifact, 162 distinct electrical depolarizations per minute. Dr. Lansing reached over and placed her fingers on his carotid pulse. She counted while watching her watch. 30 seconds. Then, his pulse is 100. Mechanical rate, not electrical. That's not possible, I whispered. She didn't answer. We both stared at the monitors, watching his heart generate electrical signals that somehow didn't translate to equivalent mechanical contractions. The heart was beating to its own rhythm, independent of its own electrical system. Call Dr. Thornton, Dr. Lansing finally said. Howard Thornton was the chief of cardiology. Get him here now. And Nora, she looked at me directly, don't chart this yet, not until we figure out what we're seeing. Dr. Thornton arrived at 6:45 a.m., 15 minutes before my shift was supposed to end. He reviewed everything with the methodical precision of a researcher. He verified our findings personally, checking the pulse against the monitor, watching the echo images, reviewing every test result. Has anyone else seen this? He asked. Just us, Dr. Lansing said. I wanted your opinion before we involved anyone else. He nodded slowly. I've never seen anything like this. Not in 30 years of cardiology. He turned to the patient, who was now awake again after the sedation wore off. Mr. Callahan, how do you feel right now? Good, he said. Really good, actually. When can I go home? Dr. Thornton's expression became very controlled. We need to run some more tests first. Make sure everything is healing properly. He gestured for us to step outside the room. In the hallway, he spoke in a low voice. I want to see if this persists. Keep him monitored. Don't give any medications that might suppress the heart rate. I'm going to consult with electrophysiology. There has to be an explanation. But over the next 3 days, no explanation emerged. His heart continued to generate electrical signals at rates between 150 and 170 beats per minute, while mechanically contracting at rates between 95 and 105. The discrepancy never resolved. He remained completely asymptomatic. His cardiac enzymes normalized. His ejection fraction stayed elevated at 65%. And then, on the 4th day, 2 more patients arrived with similar patterns. The first was a 57-year-old woman named Beverly Stanton, who came in with an inferior wall MI. We did the same emergency intervention, opened her blocked artery, placed a stent, admitted her to the CICU. 8 hours post-admission, her heart rate began to climb while her mechanical contractions remained steady at a lower rate. The electrical mechanical dissociation was identical to Callahan's case. The second was a 69-year-old man, Eugene Larkin, with an anterior MI. Same pattern, same impossible discrepancy between electrical activity and mechanical function. Same complete absence of symptoms. Dr. Thornton called an emergency meeting. Everyone who'd been involved in the cases, nurses, cardiologists, the echo techs, the cath lab staff, crowded into the conference room. We have 3 patients exhibiting cardiac electrical activity that doesn't correlate with mechanical function. Dr. Thornton began. All 3 are post-MI. All 3 had successful revascularization. All 3 are clinically stable, but displaying parameters that are, frankly, physiologically impossible. Could it be the equipment? Someone asked. Some kind of systematic error in the monitors? We've checked that, Dr. Lansing said. Multiple monitors, multiple manufacturers. We've verified the rhythms with manual pulse checks. The electrical activity is real, and it's genuinely dissociated from the mechanical activity. And their cardiac function is better than it should be, I added. All 3 have preserved or improved ejection fractions, despite significant infarctions. The room fell silent. Finally, Dr. Thornton spoke again. I've contacted colleagues at other cardiac centers. I want to know if anyone else has seen this pattern. In the meantime, we continue monitoring. We document everything, and we keep this contained. I don't want this leaking to the media until we understand what we're dealing with. But there was nothing to understand. The pattern continued. Over the next 3 weeks, 7 more patients developed the same electrical mechanical dissociation after MI treatment. All of them recovered better than expected. None of them had any symptoms. All of them had hearts that somehow beat mechanically at different rates than their electrical systems indicated. I stopped sleeping well. I'd come into work and check the monitors, watching for the telltale sign, the climbing electrical rate, while the mechanical pulse stayed steady. When it appeared, I'd feel a mixture of dread and fascination. These patients were doing better clinically than they had any right to. By every measure of cardiac function, they were improving. But the mechanism violated everything I understood about how hearts worked. The other nurses started to notice. Kelsey pulled me aside during a shift break. "Nora, what's going on with these MI patients?" she asked. "The electrical mechanical thing." "I've been nursing for 20 years. I've never seen anything like it." "I don't know," I said honestly. "Dr. Thornton said not to talk about it." She lowered her voice. "But people are talking anyway. Some of the day shift nurses think maybe it's the stents. Maybe there's something wrong with the new generation stents we've been using. Maybe they're conducting electrical signals differently." "We've checked that," I said. "The stents are inert metal. They can't affect electrical conduction." "Then what is it?" I had no answer. The breaking point came on May 12th, exactly 4 weeks after Callahan's admission. I was doing rounds at 3 a.m. when I stopped by his room. He was still with us because Dr. Thornton wanted to keep monitoring the long-term pattern. Callahan had been stable for a month, his heart rate maintaining the same electrical-mechanical dissociation without any deterioration. I checked his monitors out of habit. Then I froze. His electrical heart rate was showing 248 beats per minute, ventricular tachycardia territory, a rhythm that should make effective cardiac output impossible, a rhythm that should make him unconscious or dead. I ran into the room. He was awake reading a book on his tablet. "Mr. Callahan!" I grabbed his wrist, feeling for his pulse. It was steady, strong, about 90 beats per minute. "What's wrong?" he asked, looking up calmly. I stared at the monitor. 252 beats per minute now. The electrical tracing showed rapid, regular complexes that should indicate a life-threatening arrhythmia. "How do you feel?" I asked. "Fine." "Why?" I couldn't answer. I called Dr. Lansing, then Dr. Thornton. Within 20 minutes, they were both there, along with an electrophysiologist named Dr. Vivian Garrett, who'd been consulting on the cases. We stood around his bed watching the monitors. His electrical rate climbed to 270 beats per minute, then 290. His mechanical pulse, measured both by palpation and by arterial line, stayed rock steady at 92. "This is impossible," Dr. Garrett said. She was a specialist in cardiac electrical systems, someone who'd spent her career studying arrhythmias. "The heart can't do this. The electrical signals control the mechanical contractions. They can't be independent." "But they are," Dr. Thornton said quietly. We watched for 3 more hours as his electrical rate climbed to 320 beats per minute, faster than it should be physically possible for cardiac tissue to depolarize and repolarize. Through it all, his mechanical heart rate stayed between 90 and 95. His blood pressure remained stable. He read his book, dozed off, asked for breakfast when the morning meal cart came. At 6:30 a.m., Dr. Thornton made a decision. "We're transferring all 10 patients to the research unit," he said. "Full workup, genetic testing, advanced imaging, everything. There's something happening here that we don't understand, and we need to figure it out before we treat any more MI patients." But that morning, before the transfers could happen, something changed. I was finishing up my charting when I heard alarms from multiple rooms simultaneously. Not just one patient, all 10 of the patients with the electrical-mechanical dissociation were alarming at once. I ran to the nearest room. It was Beverly Stanton. Her monitor showed electrical asystole, a flat line. No electrical activity at all. But when I grabbed her wrist, she had a pulse. I looked at the monitor again. Completely flat. No electrical signals, no P waves, no QRS complexes, no T waves. Just a straight line that meant electrical death. "Beverly," I shook her shoulder. "Can you hear me?" Her eyes opened. "What's wrong?" "Your monitor." I stopped. What was I supposed to say? Your heart has no electrical activity, but you're alive and conscious? I ran to the next room. Eugene Larkin, same thing. Electrical asystole on the monitor. Strong, palpable pulse at his wrist. All 10 patients. Every single one of them had lost all electrical activity. Every single one of them had mechanical hearts that kept beating anyway. The CICU erupted into controlled chaos. Doctors and nurses swarmed the unit. We checked and rechecked the monitors. We verified the findings with EKG machines, with multiple lead placements, with every method we could think of. The results were consistent. 10 patients had hearts that were beating mechanically, with absolutely no electrical activity driving them. Dr. Thornton looked like he'd aged 10 years in 10 minutes. "This isn't cardiology anymore," he said. "This is something else." He was right. We'd crossed a line from medical mystery into something that couldn't be explained by medicine at all. Over the next week, the hospital administration got involved, then outside consultants, then researchers from the CDC and NIH. Everyone wanted to study these patients who had impossibly living hearts. But I'd stopped wanting to understand. Because on the night of May 18th, working the night shift alone with Kelsey, I was sitting at the nurse's station when I saw something through the glass of Dennis Callahan's room. It was 2:47 a.m., almost exactly the same time his heart rate had first started climbing a month earlier. He was sitting up in bed, awake, staring at his own chest, and as I watched, he slowly placed his hand over his heart. I couldn't hear what he was saying from the nurse's station, but I could read his lips. "Thank you," he mouthed. "Thank you for staying." He was talking to his heart, and then, I'll swear to this until my last breath, I saw his chest glow. Not bright, not like science fiction, just a faint, warm luminescence beneath his skin, right over his heart. It pulsed once, twice, 3 times, then faded. I stood up so fast I knocked over my chair. Kelsey looked up from her charting. "What's wrong?" I couldn't speak. I just pointed at Callahan's room. By the time we got there, the glow was gone. He was lying back down, eyes closed, appearing to sleep peacefully. His monitors showed the same impossible pattern. No electrical activity, but a steady mechanical pulse. "Did you see something?" Kelsey asked. I almost told her, but the words stuck in my throat. If I said what I'd seen, if I admitted that I'd watched a man's heart glow independent of any known physiological process, I'd be admitting that we weren't dealing with a medical phenomenon at all. "No," I lied. "I thought I did, but no." The next morning, I submitted my resignation. I told Dr. Thornton I was leaving for family reasons. He didn't question it. Several other nurses had already quit, unable to cope with the uncertainty of what we were witnessing. He thanked me for my service and wished me well. I worked my final 2 weeks. During that time, 3 more post-MI patients developed the electrical mechanical dissociation, then the electrical asystole with persistent mechanical function. The pattern was consistent now, predictable. Whatever was happening, it was happening to every MI patient who came through our doors. On my last night, I did final rounds. I stopped by Dennis Callahan's room. He was awake. "You're leaving," he said. It wasn't a question. "Yes, because of us." I didn't deny it. "Can I ask you something?" "Of course." "What does it feel like, your heart, when it's beating without the electrical signals?" He was quiet for a long moment. Then, "It feels like it's beating because it wants to, like it chose to keep going, like it's not just a pump anymore. It's making a decision to live." "That's not how hearts work," I said softly. "I know," he replied, "but that's what it feels like anyway." I left Providence Regional Medical Center on May 31st, 2024. I didn't stay in nursing. I couldn't. Every time I thought about picking up another cardiac monitoring job, I'd remember those 10 patients whose hearts beat without reason, without electrical impulses, without following any known law of physiology. I'd remember the glow. The hospital never released any information about the cases publicly. I've searched. The pattern apparently continued. I heard through former colleagues that by July, they'd stopped doing emergency cardiac catheterizations altogether, because every revascularized patient developed the impossible electrical mechanical dissociation. Eventually, they started transferring all MI patients to other facilities. I don't know if the pattern spread to other hospitals. I don't know if those 10 patients are still alive, their hearts beating to their own mysterious rhythm. I don't know if what I saw that night was real, or if the stress had finally broken something in my ability to perceive reality correctly. What I do know is this. I spent 11 years learning that the heart is a mechanical pump, and I ended my career watching hearts that decided to keep beating after every mechanical explanation failed. I think about all the patients I saw over those 11 years. The ones who arrested and we couldn't bring back. The ones whose hearts stopped and stayed stopped despite our best efforts. I always thought we lost them because the damage was too severe, because the muscle was too weak, because the electrical system failed. But now I wonder if we lost them because their hearts chose to stop. And I wonder what that means about the ones we saved. I wonder if the heart knows more about staying alive than we've ever given it credit for. I wonder what mine would choose if it came down to it. And I wonder how many other nurses and doctors have seen impossible things in their patients' hearts, but never said anything, because admitting what we'd witnessed would mean admitting that everything we learned was incomplete. The heart isn't just a pump. I don't know what else it is, but it's not just a pump. And that's why I'll never work cardiac care again. If you enjoyed this story, you'll love what's coming next. Hit subscribe so you don't miss it.